Yeah, thank you. I'll just do a bit of an introduction, then we'll get cracking. So my name is Chris Carrigan. I'm the expert data advisor to Use My Data, and these are sort of mini education sessions which we try and run on particular topics. All the topics are suggested by either people who've emailed me or Alison or Emily, or have registered an interest on any of these previous ones we've run for something to cover. And a topic which has been very, very common is, can we talk about how a researcher gets access to data, and how can it take so long for a researcher to get access to data to do their job? This is data about you and I and everybody else out there, patient data. So this has been a really popular session, and we've got more than we've ever had on these. We'll try and keep it informal. With knocking up to 40 people, it's going to be difficult. But what we normally do is we'll let the speaker run through a particular topic. If there's anything that's burning, either stick your hand up, or with 40 people, if you could say, could I ask a question on your microphone? Otherwise, there's plenty of time after Richard's been through his talk to pick up any questions there as well. If there are any things you don't understand, please shout. These are meant to be informal sessions, and we'll try and keep it that way. So was there anything else I was going to say? I don't think so. So first of all, let me say thank you to Richard Feltbower. Richard, he'll introduce himself. He's based up in Leeds, as am I and a few others. He's somebody I've known a long time, and I know some of the work that they've done, which I know that he will describe. I know the quality of the work they've done, the difference it's made to patients in the UK. And he's just a good example of a researcher needing access to data about us to do the job, but having difficulty getting access to it. So he's a perfect guinea pig for us to go through here about the steps he has to go through and some of his hurdles. So Richard, I shall hand over to you. You can share slides if you need to, or you can do it however you want to prefer.
Okay, so yeah, thank you for the kind introduction, Chris. So yeah, so I've been a cancer researcher, children's cancer researcher now for about 25 years, and I was very fortunate to take over running the Yorkshire Register of Cancer. So it's a young person's cancer registry. It doesn't look at those that are diagnosed in middle or older ages, so adult ages, but it does look at children and young adults. So anyone diagnosed with cancer up to the age of 30, we're interested in anyone in terms of whether they've gone back into hospital after they've had the cancer treatment, why they've gone back into hospital. So is it for other health reasons? Is it because of complications of their treatment? So essentially it's following these young people up to start with, and some of them now are sort of in their late 50s, early 60s. So the register's been going since the 1970s. So we're starting to get a very rich data source of follow-up and monitoring the kind of real long-term outcomes. So unlike the typical age when you might be diagnosed with cancer as an older adult, in your 60s or 70s, these are young people. They've got most of their life ahead of them, hopefully. So that's why we want to make use of lots of other data sets, like hospital admissions, like primary care, like education, like employment, to sort of see how their life chances fare compared to their peers without having had a cancer diagnosis at that young age. So I'll talk a bit about the register for sort of 5 minutes, just to kind of give you some kind of context. So essentially it's a long-running cancer register. It's different to the National Cancer Register. It's specifically focused on young people, so anyone under the age of 30. It's been funded on a shoestring really by the Candlelights Trust. So they're a small children's cancer charity in Leeds, and they've probably pumped in something like £1.5 million over the last 35 years. So essentially that covers a statistician to analyse the data, and a data collection manager officer to pull all the information together. So you can kind of read through these bullet points in terms of the purpose. One of the most important things that we've started to look at more recently is, yes, general patterns of disease, why young people get cancer first and foremost, how we can kind of reduce mortality rates. But in particular, it's this kind of third bullet, understanding long-term health and social outcomes for these survivors. So in particular, once they get to 5 years out from their original diagnosis, that's when we start to really sort of unpick their kind of their morbidity, their health outcomes, and also their social outcomes. And we hope that that might provide some reasonably good evidence around patient benefit, public benefit of holding this data without anyone's consent. So that's one of the unique features of the data set. Just like National Cancer Registration, we don't ask for explicit consent. It's opt-out. It's an opt-out model. So people can opt out if they wish, but clearly if they opt out, then that means we get rid of any personal identifiers, which means we're unable then to link their information to other really useful data sets like education, employment, etc. So the last bullet here at the bottom sort of talks about this idea. One of the unique features, we've got approval to link to primary, secondary care data. So that's GP data, that's hospital episode data, that's mental health outcomes, very big topic at the moment, very topical topic, as well as education, social outcomes. So it's a small team. It's myself, Adam Glazer, who's the clinical director. We've got 2 or 3 PhD students looking at particular aspects around long-term outcomes, complications around treatment, toxicity, for example. And we've got a data manager as well that looks after all the lovely information. There's a website. If you want to have a look at more information about what we do, there's a link there, the YSR CCYP link. Do please have a look at that. So the reason why I want to put the context in terms of the Yorkshire Register, which we hold in the University of Leeds, being separate to the National Cancer Registry, is we still have to go through the same hoops. So in terms of having ethical approval, which is absolutely essential, but also we have separate information governance approval to process this data. So it's particularly quite sensitive data. It's got identifiable information in there so that we can link names and NHS numbers to other GP, secondary care, education and employment data sets. So we had that approval. When did that come through? So the information governance approval came through about 2002, something like 2002, 2003. It's gone through a few iterations. It's now overseen by the confidentiality advisory group, and every year we have to sort of go through an annual review process to make sure we're doing the right things. We're still showing patient benefit. We're still within the kind of governance approvals process that's been signed off. So in terms of achievements, this is a kind of very quick summary. So we've started to really unpick some of these aspects around mental health episodes. So how often young people come back into hospital, for serious mental health reasons, the kind of increased risk of cardiovascular outcomes, increased risk of respiratory complications. We've just started or just about to link to educational data. So that's the National Pupil Database, which is held by the Department for Education. And we've also linked with other national treatment data sets like chemotherapy, radiotherapy, and so on. So we've been reasonably successful, but we've also had to do this without any real sort of administrative or research support resource. So it's usually kind of PhD students or myself or Adam or the data manager having to go through these processes that usually takes about a year, actually, at least. So this is these kind of questions, so, sort of educational attainment. What's the impact of a cancer diagnosis on a young person's educational outcomes as they go through school, college, or university? How does that happen? Is it a big problem? Is it a small problem? How does it compare? How do their outcomes compare to other young people without a cancer diagnosis? These are kind of almost the very fundamental questions, and it's almost as if you have to justify everything to the nth degree, when actually there's a very clear and obvious. If you speak to any kind of cancer survivor as a young person, their families themselves, they want to understand how that diagnosis has affected their education, to see where we might actually intervene and develop some new interventions to support these young people, particularly the more vulnerable individuals. So having to fill in a kind of 25, 30-page application form justifying why you want to do all this does seem slightly disproportionate. Similarly, employment data. So we've had a real block with employment data. So education is reasonably okay, even though it takes a while. But employment, DWP, Work and Pensions Department, have essentially said there's no ministerial appetite for this kind of linkage. they don't really see any benefit themselves to this data being linked. Again, we went to HMRC, which looks after some of the kind of benefits payments data, and again, there's no the kind of message, well, there's no ministerial appetite. So that's the kind of blocks that we've got ourselves. I thought I'd go through a particular project that was written up last year, and I was involved in this in a kind of very kind of peripheral aspect. So I'm one of a number of people. So Christina Paley, you may have seen Christina on the news over the last 2.5 years talking to the media about the impact of COVID and coronavirus on public health. So she's a very, very well recognised, very experienced researcher looking at health outcomes. And she leads a team based in London, so it's the University College London. And what they wanted to do is they didn't just want to link 2 data sets together, they wanted to link about 5 different data sets. So one was a heart disease data set to look at how they fared going through the NHS, following a congenital diagnosis at birth. It was linking to intensive care data. There's a pediatric intensive care data set. There's an adult intensive care data set they wanted to look at. There was hospital admissions data. So there's 4 or 5 of these different data sets. So it's a really nice example of how really experienced researchers have kind of come up against these kind of bottlenecks and really slowed things down. So if I'll just stop sharing this particular screen. I'll just start sharing the actual paper if I can just find it, because I've made a few notes on there. So the first thing, just to kind of by way of context, so this is the idea of this particular study was to link clinical and national audit data, NHS data, around these 5 data sets. So it was called Launches QI. And the idea was to understand more about how people with coronary heart disease, or CHD here, how they actually, how their care is managed, and whether it's managed well and actually is fit for purpose. So they talk about the problem. The problem here is linking 5 big national data sets. It's hard work, it's slow, and sometimes it does actually really put you off being a researcher. People actually, I know colleagues who've actually left the research and academic environment because of these kind of barriers. It just takes so long to get this data out. So as I said before, you might not be able to see all of the kind of text, but it was using some national congenital heart disease data. So those that are born with a particular genetic disease around the heart condition, and they wanted to link to pediatric intensive care data, so following from birth all the way through childhood, adolescence, and into adulthood, to understand how their care has been managed and whether it's been managed effectively. So it's 5 data sets. And table 1, they've set out all the different documentation that's required. So the summary here is 47 different documents were required. 47 different applications, in effect, application forms had to be completed. So totally 384 pages. So unless you have the patience of a saint, it does really test you in terms of how you've got to go through the same thing multiple times, demonstrating what's the patient benefit, what's the research question, what do the outputs look like, how long is this going to take. And it's not just submitting the application once, it's submitting multiple applications and actually going through a kind of process of, right, okay, so you send it through for the first go, then it comes back with feedback, and you go through a kind of 3 or 4 different iterations to actually finally get the approval. So 162 submissions were required for this particular study. So it is time consuming, it's complex, it's iterative. I was talking about the workload required. So unless you are a big research intensive university, you will be put off because normally you're struggling to fund your own salary, never mind a whole team's worth of salaries. So you do need a critical mass, and this particular research team, so Christina Paley's team, they had a 1 day a week, 20% FTE person who was the research coordinator. So it was their job to pull all these applications together. They realised very quickly they needed to double that. So it went from 1 day a week to 2 days. So that's just 2 days a week doing the kind of administrative support for this research project. And that's not to include other people's times, so the principal investigators, the other researchers, and they really did underestimate how long this whole process would take. Figure 1 here, this just kind of very nicely summarizes all the different information that's required. So even before you get to submitting the data applications to each of the 5 data sets, you still need to kind of produce your kind of research ethics protocol, information governance information. You've got the CAG form I've talked about. You've got the IRAS, which is the ethics form. You've got insurance to make sure that if you do something silly with data, then your institution's covering you for any indemnity. That all then gets collated by a local research office, and then it goes through these kind of data applications. So national congenital heart disease, PICU, so pediatric intensive care unit data, PICUNET data, intensive care for adults, ICNARC, HES data, which is hospital admissions, ONS data for mortality. So all these different data applications have to go in. They all have to be covered by various data sharing agreements. That's more paperwork. So that's where your data protection officer has to kind of sign these off, or your contracts team. So it is a kind of almost endless array of administration. So how long did it take this particular study? Well, they estimated, so including all the permissions, all the processes, all the ethics and the information governance, it took about 8 months to actually pull these together. The applications then took between 3 and 7 months. And then actually it took up to 10 more months to even get the data. So you're talking 2 years before you actually get your hands on the information you need, as Chris was saying. That, this is the kind of constant battle. So if you're trying to fund a 3-year project to look at congenital heart disease, and you're saying, well, actually it's going to take me 2 years just to kind of get hold of the data, and then I'll have the final year to do the analysis and then produce the papers or the abstracts, the conference presentations. A lot of funders are both think, well, actually, should we really be funding this project, 2/3 of which is purely administration, essentially, and a lot of the administration is duplication. So there is a lot of bureaucracy. Data sharing agreements, they always need updating. If you have new members of the research team, you need to update their names, their access requirements. So that needs to happen every time. I'll just switch this view around so that I'll be able to see things a bit better, and I can get my keyboard to work. So this table 1, this is the summary of all the different study forms that need to be filled out. So there's data protection, there's IRAS, there's ethics, there's CAG, there's HKIT, which is another part of NHS England, which looks after the PICUNET audit. And there's so many here. So there's about 40-odd different forms that need to be submitted. So it really is a kind of mammoth task. And you can see here on the right-hand side, these are the number of pages. So the CAG form here, that's the kind of winning form. That's the most lengthy form there, 40 pages worth of information that they ask for. And that had to be submitted 5 times. So this really does add up to a huge amount of effort. So let's bring that back. So I suppose, why are we having to go through all these hoops? So one of them is kind of risk aversion, and particularly a very strong legal principle within the Data Protection Act that says, or the EU Data Protection Act as was, which means that institutions, they can be fined up to 20 million euros if they do the wrong thing with data, with your personal data, or 4% of a particular company's annual turnover. So yes, there's a big concern about how long these things take, but I think it's always balanced by, well, actually, we've still got to abide by the various Data Protection Act principles, and that's absolutely right. So maybe that's the kind of, the lawyers of the legal teams are kind of always there in the background. So actually, we've got to do this right. We've got to do this all 382 different pages. We've got to do it right, because otherwise we'll get a huge fine. So that's all fine. So approvals actually finally they get in place. You've then got to process gain that. You've got to understand the kind of access process to actually get hold of the data and actually then do the data linkage. So we've got here 5 different data sets. So, I think this was a 5-year funded study. So at least they had another 3 years to actually do the number crunching, the real complicated, complex, checking to make sure that the right person actually was tracked correctly all the way through the data. So there's those sorts of challenges out with or when you finally got these approvals in place. One of the really frustrating things for me as a researcher is you tend to use the same data or similar data sets, and you slightly changing the research question. So it might be, I want to look at cardiovascular disease in terms of what that risk looks like for cancer survivors. Okay, that's fine, right? And then you produce a paper. They say, well, actually, I want to look at those that have had a stroke, for the next grant. So you're doing a kind of progression of the same data, and every time you change your research question, even if it's a small change, it almost feels like you've got to start again. So even though you've got the approval once, you've then got to go back and ask for the approval again. Just say, well, actually, it's not overall heart disease I'm interested in, it's now stroke events. So this is why you've got to be you can be quite canny and cunning and say, try and think of almost everything that you want to look at. But again, that is quite costly because you always usually have to renew these data sharing agreements, which can be quite expensive as well. But it just demonstrates how clunky the system is and slow. So the kind of take-home messages here, this was a kind of advice. They finally got onto the kind of advice on page 7 here. So speak to experienced researchers, invest in research assistants, invest in study coordinators. They are real key individuals. Have a flexible startup period. Make sure you've done your homework, you know what's expected. This took 2.5 years to create the linked data set. So, a lot of funding would be wiped out just by actually waiting for the data. And they came up with some system improvements, what they called how to improve the whole process. And essentially, if you look at all these different bubbles, essentially the key word here is streamlining. Things need to be streamlined, and it's an impressive process if you think about how many different multi-agency organisations are involved in getting any particular one single health data application or social care data application through. There's a whole host of different quangos and organisations that you have to adhere to and align with. So what's the best solution? Well, obviously the best solution is just have one single application rather than 40 odd. So how you'd agree that, I'm not quite sure, but it's clearly, if you look at any of these applications, whether it's ethics, information governance, they're pretty much the same sorts of headings. It's what's the patient benefit? What's the key research question? How secure is the data going to be? Where are you going to hold this data? It's pretty much the same question, but asked in a very, very slightly different way. So that's the frustrating thing. It's not just a copy and paste from one to another application. What else have they said? So some sort of central authority processing, improving applications, implementing linkage, reducing the number of data controllers. So these are the bodies that are kind of the data owners, and they're in charge of who they release the data to. So that clearly would be fantastic. I guess the question is always going to be, well, who's going to pay for that central authority? There's a lot of existing government groups like the Health Research Authority that looks after ethics, that looks after information governance approvals. Is that the best place for that central authority? They talk about universities or research organisations supporting centralised study coordinators. Absolutely agree with that. And it's also about interpretation or different ways of interpreting the same regulation. So I'm sure many of you have heard about GDPR, so the EU General Data Protection Regulation, and that came in about 4 years ago, and everybody got very stressed and worried and anxious. Any kind of researcher is sort of trying to understand what is required for this GDPR, these new data protection laws. So it's fine having a law, but it's kind of, well, if you're a lawyer, you can interpret things in slightly different ways. You can read things and think, well, actually, we need to do this to the absolute letter, whereas other people are a bit more relaxed and think, well, actually, yes, as long as we can kind of demonstrate that it's the data is reasonably safe, it's not going to be absolutely perfectly safe, but it's as safe as we could possibly make it without having to spend kind of Amazon levels of income. So this can be done. This has been this kind of expedited process, as the authors talk about. This was done for COVID-19 research. So a lot of the kind of regulatory hurdles were relaxed over the last 2 years, just so that we can share information, researchers, clinical audit managers, NHS analysts, in a much more friendly, efficient, and quick process. So if we can do it for COVID, we can do it for other conditions as well, I'm certain. So streamlining is the key. It's how we might go about doing that in a kind of coherent way, I guess. And it's making sure that we provide the kind of infrastructure now, so that long after I've retired, the next generation that's coming through, they don't have to go through the same arduous processes, because otherwise we're not going to get we're never going to attract the kind of very best in the business in terms of analytical expertise and research expertise. People are just going to go off and do something else. So I'll just finish off just by going back to my original slide deck, and it's probably something that you may have seen before anyway. So hopefully that's come back up on the screen. So what needs to change? So I think Chris did a previous session quite recently around the Goldacre review, which is one of the other educational sessions. So that was a really very good timing, actually, because the recommendations in that report essentially address pretty much everything that I've said in the last 25 minutes. So it's about investment in these kind of data platforms, secure data platforms. We don't need 20,000 of these platforms at every single research institution. We just need a small number that people can use in an easy way. And I think the other key message that came out of the review was rationalising the approvals process. So having a single common application form for everything, coordinating shared meetings where you've got to get approval from multiple different organisations, building institutions to help users who face challenges. So I think I saw Rob on the call as well. So Rob French from Cardiff, and he's been really helpful to me about how to kind of unblock some of these challenges. So actually speaking to other researchers, I think, is also very helpful. But there's a kind of central pot of expertise that we can use and share, then that would seem very sensible. And also recognising that people address risk in different ways. Some are very risk averse, some are less, or a bit more relaxed. So it's making sure that data controllers, those people that are in charge of data, it's mainly it's NHS data, it's your data. They don't want to be overly protective of that data, and in fact, they're kind of blocking people from accessing it who have a very clear and obvious purpose around patient benefit potential. So I'll leave it there, Chris, if that's okay. And I'm very happy to open up to questions for the next half an hour or so.
Richard, thank you. That was a really good walkthrough of a life of a researcher, really, trying to get access to data. People can ask questions however they want. There's a few ways. One of the easiest way is if you, at the bottom of the screen, there's a button called reactions, and it says, do you want to raise a hand? Or if your video's on, you can try and wave at me, but if I don't see you, you can just shout and ask a question. I suppose one thing to reflect on, thank you, Paul, come to you in a second. One thing to reflect on is that all you heard described there, the timescales, the forms to fill in, the amount of money it takes, the amount of time it takes, is one relatively smallish research group. If you think about the other research studies that we've all come across in our lives, and the other research groups, the other universities, the other organizations, the other companies, and multiply all this up by the amount of time they're all taking. I think you get some sort of picture by what Richard is describing in terms of the real need to get some efficiencies. So that's my immediate take home. What the other thing that struck me as Richard was talking through the time and it takes to actually produce the end result of the research, which hopefully is designed to show what can be done to either save lives or improve treatments or improve care. A 2-year delay on every research project is a 2-year delay in getting the results out, and a 2-year delay on people who could have been treated or could have been given better care or could have been saved. So for me, that has to be the absolute primary motive for improving the way, the mechanism that researchers can get access to data, which is still safe, which is still secure, which goes through the appropriate ethics, but eliminates some of the potentially wasteful, repeated multiple steps. So I'd like to thank Richard for his really good presentation. I hope that was interesting. And I hope it's useful. I hope you can take something away from that. If you've got any comments, please feed them back in either to myself or Emily or through any of the routes on this. And similarly, if you've got any suggestions for what we'd like to cover at the next few education sessions, they're all set up or designed by you. Please let me know. Otherwise, I'll have to make some of my own up, and that's never a good idea. So thank you again for your time. I hope that's been useful, and have a nice, warm rest of the day and a nice weekend. Thanks, everybody.